Joints and bony structures. So I'm going to spend a lot more time on the first third to a half or so of this, and then less time on the second part. The second part of this, or the second half of this, is a lot of pretty straight memorization. I'm also going to test a little bit less on that information than the stuff in the first part of this. The first part of this is a lot more application-y stuff and not just cold memorization. So anyway, let's talk about the vertebral column. This lecture is about joints, and the vertebral column is a long series of bones that all indirectly articulate with, well, directly and indirectly articulate with one another. And your spine has curvatures to it as well, right? Your spine is not just a rod. Now, the curvatures are named for the regions that they go through. So your cervical region goes through your neck. Your thoracic spine goes through your thorax, your thoracic cavity, or behind your thoracic cavity. Your lumbar spine goes through the lumbar region of your body, or basically analogous to your abdominal area. And your sacral spine is down embedded in your hips, basically, right? It's between your two ilia. And they curve in this snake-like fashion. The cervical curve is concave posteriorly. The thoracic, and just to exaggerate, is convex. Lumbar is concave, and sacral is less so, but still convex. The mnemonic device that you can use for how many bones in each of these regions are common meal times, or sort of common meal times. The cervical spine has 8 cervical vertebrae. You eat breakfast at 8 a.m. The thoracic spine has 12 vertebrae. You eat lunch at about noon. The lumbar spine has 5 bones, and I guess you could eat dinner at 5 p.m., although most of us probably wait longer than that. Little kids eat at 5. Okay, so 8, 12, and 5 common meal times. The sacrum is actually 5 bones, but they're fused together. So for an adult, it's really just one big bone. If you look at a sacrum, and you look at the posterior aspect of the sacrum, though, you'll notice that there's a bunch of bumps in this ridge down the middle. Now, if you feel like the middle of your back, you can feel all those bumps in the middle of your back. You can feel your spine. Those are the spinous processes of your vertebrae, of each of your vertebrae. If you look at the sacrum, you just have this bumpy ridge, and there's 5 bumps. Those represent the 5 spinous processes that you would have if the sacrum were still 5 separate bones, as they were in utero. The coccyx is the last little bit. That's also concave posteriorly. It's angled a lot more forward in men than in women for childbirth reasons. If your coccyx was angled like this and you tried to have a baby past it, that would be pretty hard and painful. So women's tend to be like this. And even still, if you've had a baby, it will angle out a little bit more than that sometimes. The coccyx is 4 bones that have been fused to one another. The sacrum, the sacral bones, have been fused to one another, but the sacrum is not fused to the coccyx, and it is not fused to the 5th lumbar vertebrae. The coccygeal bones, the 4 coccygeal bones, are fused to one another, but not to the sacrum. There are still joints there. The curvatures develop in response to your relationship to gravity. So, you actually create these curvatures as you learn to walk. So if you had all your vertebrae stacked up on top of each other like that, gravity would be pulling all of them down right on top of each other. And every time you take a step and you apply a force, that's going to just whip right up the whole length of the spinal column. There's going to be not a lot of dispersion of the force. So what we have instead is this sort of curvy pattern, right? Ultimately, its direction is straight down in the same direction of gravity, but when you apply a force with any given step, some of it can diffuse on its way up. so that your cervical spine experiences very little additional stress with every step that you take. Your sacrum takes a lot of it. That's one big fat fused bone, isn't it? Your lumbar vertebrae take a lot of force. They're pretty thick. Your thoracic spine takes less force still. They're thinner than the lumbar spine, and your cervical spine are thinner still, based on how much force they're going to take, how much impact they're going to have to withstand in response to any given step. The curviness helps disperse that force further, helps disperse that force in the first place, and the bone size gets smaller in response to that dispersion. Now you create that, like I said, when you learn to walk. So in utero, you kind of only want to have one spinal curve. The one that's basically one big convex curve. The spinal curves that you retain through adulthood that are also convex are called your primary curvatures. Your thoracic and sacral curvatures are primary curvatures. They're convex like you were in a baby. Your secondary curvatures develop later on, and that's all your convex ones. So your lumbar and your cervical curvatures are formed. Your cervical curvature is formed by your efforts to hold up your head. If your head's down at your chin like that, like a newborn's would be if they weren't being actively supported, your cervical spine doesn't have to bend out. It's still just convex like it always was. But as you work those muscles and hold up your head, you can't bend in like that anymore. It gets forced into this arrangement. Similarly, as you learn how to stand, you create a straight down shape instead of bowed up like that. You know, your legs are up in front of you like that, crawling or sitting or whatever it is you're doing as a little baby. You now force your legs downwards and make it so that you're standing against gravity. It means your sacrum is going to have to bow out more like this. And to keep things aligned, where you're not putting really undue stress on your back, your lumbar spine is going to have to curve in. And you end up with this S-shaped series of curvatures. These curvatures, again, disperse the energy with any given step so that your vertebrae and your body as a whole are disrupted the least amount possible by the force that's put on your body by each step. Your spine acts like a spring much more than a rod. Abdominal curvatures can result in back pain and gait problems and imbalance and worse balance because your spine is not oriented vertically overall against gravity like it would be in a regular spine. So if you have different kinds of abnormal spinal curvatures involve scoliosis, okay, so you don't really have that line that straight line down the back that you have, and you have more of your weight shifted this way for this person's scoliotic spine. And so you'll end up a lot of times with like gait problems more than anything. And of course, back pain. All of these things are going to result in back pain. If your back isn't nice and has all the curvatures in the right place and your weight is kept at a regular amount and you have good muscle tone to help support your bones, you kind of need all of that to keep a back that's not in a ton of pain. This vertical orientation of our spine is a relatively recent evolutionary adaptation that we've stumbled upon, I suppose, as human beings, as bipeds. It's great at what it does. You'll hear a lot of times being like, your spine wasn't designed to do this, blah, blah, blah. It is great at it. It kind of was. It's just not perfect. It still has tweaking to go to get that better. So anyway, pain is a thing for all of these. Hunchback, we've talked about with osteoporosis, that's kyphosis. Okay, so that can be a result of the result of compression fractures from weakened bone. That's overwhelmingly the biggest reason why you would end up with kyphosis. You can end up with some small amount of local kind of kyphosis right here. I think that's called like a widow's hump, and commonly, I forget what the technical term is for it right this minute. But if you spend a lot of time sitting, like, here's your head and you're at the computer, type, there's your computer, and you're spending a lot of time like that, not even hunched necessarily, but where you're leaning forward and you're holding your head up to keep it aligned straight at the screen, you can create effectively a fusion of a shortening of the ligaments and a little bit of a fusion of the bones of the spinous processes of some of those bones at the junction between the cervical and thoracic spines. And you can end up with this permanent slight little hump in your upper back that is, I don't think it causes too many problems. It causes some arm nerve problems, and it's just super uncomfortable if that happens. So I hope all of you heard that and instinctively just sat up extra super straight for a minute. Lordosis is also known as sway back. Most people know the term lordosis anymore, though. And you get that when you have a lot of weight. And this is cut off, I'm sorry, but your spine would be like, here's your head again, and your neck, spine, like that. If for some reason you had a big old belly, here's your bum, legs, right? That's a horrifically disproportionate person, but you get the picture, right? So who gets a lot of weight along their midsection like that, where you have to bow your back out to keep your balance? Pregnant women, basically anyone with a pot belly, and I guess a pregnancy is just a really big temporary pot belly. Men who carry a ton of weight around their midsection will also develop it. Anybody really, but men tend to put it on there a little bit more than women. You can also experience lordosis if you have certain kinds of osteomalacia. Any softening of the bones can monkey with the curvatures of your spine, and spinal tuberculosis, which can end up in a weakening of your spinal, your vertebrae as well, can cause lordosis. Your spine is held together, because remember, it's a bunch of different bones. All your vertebrae are a bunch of different bones that are lined up. They have to be held together somehow in line, right? So you're held together by a bunch of ligaments. Tendons touch bones. They connect muscles to bones. They just touch bones. Ligaments link bones, when we're talking skeletal stuff only. Ligaments link bones to one another. Tendons touch bone. You do have other stuff in your body called ligaments, like peritoneal foldings and stuff like that. We're not talking about those. This is a skeletal context. You have several longitudinal ligaments that run up and down the length of your spine. Okay? You have one on the front side, anterior longitudinal ligament. You have one on the back side of the bodies of your vertebrae, posterior longitudinal ligament. Okay? You have other ligaments that connect your spines to one another, that connect the transverse processes to one another. These are going to restrict movements and allow movements and keep everything in line. So the processes, or the ligaments between the transverse processes and between the spinal processes of your vertebrae, are going to go a long way towards keeping everything lined up properly and to prevent outside of a good, healthy range of motion, side to side swaying. The posterior longitudinal ligament only allows so much frontways bending, because that's how it would be stretched, right? It can only stretch so much. And the anterior longitudinal ligament prevents excessive backwards bending. Forwards bending, posterior longitudinal ligament, is called hyperflexion. It prevents hyperflexion, bent forward. If you bend your elbow to create a more narrow angle, that's flexion. If you bend your body forward to create a more narrow angle on your stomach, for example, that's flexion, hyperflexion. So the PLL prevents you from bending too far forward, where you would tear stuff or crush stuff or break stuff. Your ALL prevents hyperextension. It keeps you from bending too far backwards. Another thing that keeps you from bending too far backwards is the spinous processes, particularly of your thoracic spine. I encourage you to go back to that very first slide, like the very, very, very first one with the x-ray lady. And it's a person doing a back bend. And what you'll see is the person's cervical spine bends a lot, like a lot. And you'll see those spinous processes are really kind of small and pointy. And so you can afford to bend a lot. Your lumbar spine has big spinous processes, but they're fairly well spread out. You can bend your lumbar spine a fair bit. Your thoracic spine, and they also point out straight, your thoracic spine uniquely communicates with a rib cage, right? Now you really want to limit the flexibility of your thoracic spine because you don't want to break off the ribs back here and you don't want to crush the sternum over here, right? Or you don't want to break the ribs off the sternum or break that cartilage. And the vertebrae through the thoracic spine overlap, sort of like shingles. They're long and pointy. So you can really you can bend kind of far forward, your sternum will limit you somewhat, but you can only bend so far backward. And if you look at that x-ray on the very, very, very first slide, you'll see the cervical spine, when she's doing that back bend, is super curved. Lumbar spine, super curved. Thoracic spine, straight as an arrow. The ligaments are going to help prevent hyperflexion in any context for any of those regions, but the thoracic spine has that extra bony boundary too. The last ligament I want to talk about here is the ligamentum flavum. That's a unique kind of a ligament where it connects, like right here, the posterior aspect of the vertebral canal. So your spinal cord would be in here. This is a tube. Okay. It's surrounded by the spinous processes, the transverse processes, the pedicle and lamina of the vertebrae. And it's going to also help in recoil, aside from preventing hyperflexion and inhibiting hyperflexion. It's going to assist in recoil of the spine to keep yourself up. So the ALL is keeping you from bending too far backwards pretty exclusively. The PLL on the back of the bodies of the vertebrae, or the anterior aspect of the vertebral canal, will keep you from bending too far forward. The ligamentum flavum's main role is to help balance those, so you keep the proper curvatures and you keep the proper erect posture against gravity. And it also just provides a little extra bounce, a little less extra elastic recoil to help keep you in that arrangement. These reside kind of right behind the spinous processes, inside the vertebral column. And it's talked about like it's one long ligament. It's all referred by one singular term, but really it's a bunch of littler ones between each spinous process. It's just kind of connected with a bit of a membrane. In between the bodies of your vertebrae, you have intervertebral discs. So take a look at the spine over here. You would find your ALL, anterior longitudinal ligament, covering the anterior part of the bodies of your vertebrae. You would find the posterior longitudinal ligament on the back of the bodies of the vertebrae on the inside of that vertebral column. Ligamentum flavum, and I'm going to draw this like one long line instead of a million short ones, would be right behind that on the back, the posterior aspect of the vertebral canal. Okay? And then you would have other ligaments that connect your transverse processes to one another, connect them to the spinous, or the spinous processes to one another, the transverse processes to one another, transverse to the spinous, all to help keep things in alignment. Okay? That's the ligamentum flavum, that back one. So those are going to help keep everything in line, but you still have a vertebral body stacked on top of body, on top of body, on top of body. And the curvature goes a long way towards dispersing some of the forces with every step that you take. and minimizing the impact of gravity and inertia on any given vertebrae. But we have extra stuff that helps too. We have these intervertebral discs. They also help prevent vertebrae from rubbing up against each other and wearing down the bone itself. So these act as a cushion. They're very elastic and compressible, but they are very, very, very tough. It's made up of two components. It's made up, this is actually a picture of a herniated disc, but you have an outer, oh, that's a terrible color. You have an outer ring and an inner squidgy part. The outer ring is made of fibrocartilage and is called the annulus fibrosus. Annulus fibrosus, fibrocartilage. The nucleus pulposus, I remember because I think of this as being like pulpy and soft, is the middle squidgy part. Okay? The further down you go on the spine, the further inferiorly you move, the thicker these discs become. And if you think about it, that also makes sense. Which vertebrae have the most weight banging down on them with every step? The bottom ones. You have the whole top of your body that those vertebrae are supporting. Your cervical spine is only holding up your head, which may be big and heavy, but it's not like your head plus your thorax plus a bunch of your abdomen, right? And your arms. So they get thicker the further you go down, just like the bodies of the vertebrae do too. The annulus fibrosus's job is to prevent compression. This is fibrocartilage. It can absorb and disperse some forces, but mostly it just resists and springs back in response to stress. It doesn't compress overly much. It's just compressible enough. The nucleus pulposus in the middle, the pulpy, squidgy middle of this jelly donut, is there to really just reduce the overall force. So think about if you have a piece of wood up against another piece of wood and you clang them together, right? Wood hits wood. Clearly there's a lot of energy involved in there because it makes a loud sound when you clang them together. If you put a pillow in between them and you try to clang one block of wood onto the other one, you wouldn't hear anything and you might not even feel it in that other part of wood, right? That soft, squishy pillow really just kind of took away all that impact. It really absorbed and dispersed the force of that impact. And that's what your nucleus pulposus does. Now, if it was just nucleus pulposus, the bones can still get really close together. You can take that block of wood, hit the pillow, and get real close to the other block of wood. But now imagine that surrounding that pillow, you've got like a tire, okay? It's got some give to it, but you're not going to squish it. Now you hit that block of wood against the tire with the pillow in the middle and the other block of wood behind it. And you're not only going to not feel much force in the second block of wood, but you're not going to get anywhere close to it. And that's what your intervertebral discs do. The annulus fibrosus prevents excessive compression, keeps the bones from getting too close together. And the nucleus pulposus basically dissipates all of that force, so that as much of the force as possible, so that the next vertebrae up feels as little of that as possible. So that disc, combined with the spring-like shape of your spine, goes a really, 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 really long way towards enabling your movement as a biped through the world. This arrangement, you always see it cut long ways like this, but really it's not like you have like a ring and then the middle jelly donut here. It's more like, or the middle squidgy stuff here, where the body of the vertebrae is touching both of those. It's really more like on cross section, here's a body of a vertebrae, here's a body of a vertebrae, here's your intervertebral disc, and like the middle here is the nucleus pulposus. It's surrounded by annulus fibrosus. Okay? This can be herniated if you have a very sudden and or very severe stress on any given intervertebral disc. And what a herniated disc really is where the annulus fibrosus ruptures. That tire around the pillow ruptures. And now the nucleus pulposus, being kind of thin and squidgy and goopy, splays out along the path of least resistance. Now, look at the spine. The front of the body of the vertebrae, which would be like here, has a big, thick anterior longitudinal ligament. The back of it, here, is your ligamentum flavum. And you have a smaller posterior longitudinal ligament here. So when that nucleus pulposus squidges out, the path of least resistance is going to be right along there, right up against the base of one of your spinal nerves. This can be excruciatingly painful, and it can cause some really severe disability when it happens. How bad it is, what kind of disability you experience, what amount of pain you're in is determined by the location of it, not just along the spine, but inside that given vertebrae, and where up along it is, like how high up it is. What's it near? Is it near a big brachial plexus, a big tangle of nerves that serves the whole arm? That's going to affect the whole arm. If it's along one of your spinal nerves that maybe just serves your rib cage, it'll hurt like hell because it's lower down, but it's not going to have as much of a disabling impact necessarily. So this can be highly, highly variable. This needs surgical repair, absolutely. And even then, honestly, spinal surgeries have a much lower, of all kinds, have a much, much lower success rate than most other surgeries that we expect. They don't help people's pain nearly as often as you would hope. They don't help resolve people's disability as much as you'd hope. Oftentimes patients leave with maybe one thing fixed, but now they have a new problem. People will take pains to not have spinal surgery if they can help it. So treatments that you can employ in the meantime include things like physical therapy or steroid injections to reduce inflammation in the area that's making things worse. This part I'm going to start racing through because it blends into lab a little bit. Also, I don't necessarily test as heavily on it. The foot I'm going to spend some time on, so be prepared for that though too. And the structure of an overall joint I'll spend some time on. But these specific joints themselves are what I'm going to kind of race through. So pectoral girdle. A girdle in general refers to an encirclement. So the shoulder girdle, a pectoral girdle involves the bones and the muscles that encircle the root of your arms. And your pelvic girdle involves the bones and muscles that encircle the root of your legs, like where your femur inserts into your hips. In the case of the pectoral girdle, it's very, very, very light. You have relatively few muscles around there. Your glenoid cavity is super shallow compared to your acetabulum, for example. And a lot of what's supporting all of this are these thin, wispy ligaments and tendons that wrap around the arm and hold the arm into the glenoid cavity, but don't restrict much movement. And what you end up here is a joint in which you have a huge amount of mobility. Like move your arm around as much as you can. You can move it kind of behind your head a little bit, all in a huge circle. But because you only have these sort of relatively thin, wispy tendons and ligaments holding it in place, it breaks. It's pretty easy to break as these things go. It's really easy to dislocate in particular. So it's really good for flexibility, pretty bad for stability. Think about all the people who are 50 and over, for example, that you might know who have had rotator cuff issues. It's a lot of people. Your pelvic girdle, I mentioned, have to do with your hips and where your femur inserts into your hips. The coxal bones themselves are fused to one another on each lateral side, but they're not fused to the femur. And the acetabulum, this doesn't really show it, is a really deep, deep, deep socket. And even then it has cartilage that forms an extra tight ring around it. The head of the femur sits deep in here, and then you have the neck of the femur, greater trochanter, lesser trochanter, bone. So it sits really deep in here, and you have a ton of big, fat, beefy muscles with big, fat, beefy tendons, a bunch of ligaments that are also big and fat that really help keep the femur in place. Now think about the flexibility you have in your hip with your leg versus your arm. You can move your leg quite a bit, but you cannot move it with the same range as your arm. So in this case, you're sacrificing flexibility and range of motion for strength. But it's low down on your body. It's supporting a lot of weight. It's the major move, like place where you're moving around the world. You need that strength. The arches of your foot are actually really, really, really important. I do tend to stress this a little bit on exams, disproportionate to some other instructors. It's extremely important in terms of our ability to move through the world as bipeds. It's this and the curvatures of our spine are big reasons why we can be bipeds and why our brains can get so big. It's really cool. These two things are like a big deal of what makes us human. So the foot isn't a flat thing. You have this arch in the middle of it, on the bottom of it. You're familiar with that on your own foot, right? So the bones of your toes more or less rest on the floor, and your calcaneal tuberosity rests on the floor, but the rest is all lifted off at some sort of an angle. And you have a variety of ligaments that help support that. On the medial aspect of that curve of your foot, you have a longitudinal ligament that supports the arch that the bones make, called the medial longitudinal arch and the medial longitudinal ligament. The lateral longitudinal arch is more shallow. That's on the outside lateral part of your foot and does the same thing. It supports the lateral longitudinal arch. The lateral longitudinal ligament supports the lateral longitudinal arch. And finally, you have a transverse arch, which supports it side to side. So what this provides is an extra support so that the bones can interlock to keep their shape. So think about, like, that's how the bones are oriented anyway. So think about looking at a doorway with a curved top, and you've got all the masonry work around it. You have all these wedge-like bones, or wedge-like bricks that make up that arch. They're not squares, they're wedges. The bones of your feet, your tarsals, are wedge shaped. They're wider on top than they are on the bottom, except for your talus and calcaneus, but those are more about weight bearing. All these guys. Even your metatarsals have a little bit of that going on. They're not quite round exactly. They have this sort of triangular shape to them. So they interlock to keep that arch. The ligaments help maintain the arch, but they also absorb a lot of the impact of each step that you take and distributes it evenly across this arch so that no individual bone or set of bones experiences more stress than it has to. They offer that support, and they also are springier. Like ligaments, anything's springier than bone, right? So ligaments are springier than bone. They can take a little bit of force and then they bounce back into place. Between this and the springy aspect of the curvature of our spine, every step that we take requires fewer calories than if we walked on all fours. We have this extra sort of ligament support and curviness that helps bounce us around. It helps keep us in place without having to contract muscles. It helps spring our foot off the ground a teeny bit extra more easily than if we didn't have that orientation and we had to do all that movement with just muscle power. Having your weight distributed longitudinally also makes it so that you require less muscle mass overall to move around the world. And as we'll talk about in the next unit, muscles need a boatload of calories just to be, let alone grow or do anything. So you have a bunch of ligaments that are in place that help spring us into proper orientation and posture and help bounce us along a little more easily than if we were quadrupeds. And being upright means we don't need as much muscle mass to move around the world and just live. And our weight's distributed pretty well across the whole bottom of the foot because of those arch ligaments. So you don't have uneven stress shooting up your body with every step. For every step that we take as bipeds, pound for pound, we burn 1/3 as many calories as a quadruped. So think about that next time you're walking your dog. You're walking your dog's a biped. Pound for pound, your dog is burning 3 times as many calories to do the same activity that you're doing. That is a huge deal, because what else burns a boatload of calories, requires a boatload of calories? Your brain. And if you save that many calories, also you're upright, so your hands are free to do stuff. So you can learn, you can manipulate the world differently. Your brain needs a ton of calories, and by standing upright and moving with less energy through the world, we can spend more of those calories on our brains and wiring them and mapping them and growing them. So we can afford to have much bigger brains that way, and that's why we get to be human beings. So that's my soapbox. That's why I test on it so much. It's really fundamentally important to us as a species. This part is one of the things I'm going to sort of go through. It's very memorizable flashcard kind of material. So joints can be classified by structure or function. The structure has to do with whether or not it moves, and the functional with like how it moves, sort of. So fibrous joints are pretty immovable. Cartilaginous are based on cartilage. You have cartilage in between the bones. Some move and some don't. Synovial, there's only one that actually has a cavity, do move. Synovial joints. Functionally, if they're fused, it's called a synarthrotic joint. If it's only a little bit movable, it's amphiarthrosis. Amphi is like sort of, kind of. And diarthroses, dia really means through, so you get to move things through and around the world a lot. You find that mostly in your limbs. So again, fibrous joints have no joint cavity, mostly immovable. They can be sutures, syndesmoses, or gomphoses. Gomphoses are unique to your teeth. You only really talk about those with your teeth. Those sit in a socket, and while it is a joint, it is an immovable joint. It's a special thing it's held down with fibers with your teeth. Syndesmoses are connected via ligaments. So your radius and your ulna, you have that interosseous membrane. The interaction between your radius and your ulna is a syndesmotic joint. Your radius with your carpals, or your ulna with your humerus, those are different. But your radius with your ulna is a syndesmotic joint that moves. Tibia and fibula, same thing, only they're locked into place. They don't move around each other. And you're familiar with sutures of the skull, also known as synostoses. Those are where they're permanently interlocked. They do sort of grow together. So like you have your fontanelles when you're a baby. Those are cartilage, very, very thin cartilage. So the bones can grow and fuse, but once they're fused, they're not coming apart unless you break something. These are your fontanelles. The major one that you see on babies that you can like feel pulsing or see moving when they scream is the anterior fontanelle. You also have an occipital fontanelle, and where you have the different sutures of your skull bones, you also had fontanelles, and the bones will grow out and fill in these spaces. Cartilaginous joints, they can be synchondroses as well, where you have bones that are attached by a plate of hyaline cartilage of some kind, like your ribs, with your sternum. Your ribs don't directly touch your sternum. None of them do. You have a little band of hyaline cartilage between them that helps facilitate movement of the thoracic cavity for breathing. The epiphyseal plate also counts as a synchondrotic joint. Symphyses is a fibrocartilage band that you find between vertebrae and at the pubic symphysis. You're not going to find them elsewhere, really. Like we talked about with the spine, they're really good shock absorbers. They disperse energy an awful lot, but they do allow for some movement. Like the intervertebral discs are compressible, just not super compressible. And these can be hormonally influenced. So if you have ever been or known somebody who is pregnant towards the end, they'll complain that their joints are kind of loosey-goosey. They have to be extra careful with how they walk and stuff. And that's because they're secreting a hormone called relaxin, which sort of loosens up the fibers of these actually all of your cartilage, but mostly your fibrocartilage. It's a systemic reaction, even though the only thing your body really cares about is loosening up that symphysis, so that the baby can get out more easily. Synovial joints, I'll spend a little bit of time here, are a type of cartilaginous joint. These are what you're going to find at a lot of your big long bone joints. And all synovial joints have the same 6 features in common with one another. They have articular cartilage, which is hyaline cartilage that lines the end of the epiphyses of the bone. An articular cavity in the middle space that's filled with synovial fluid. An articular capsule that holds all that fluid in around the whole joint. Okay? You have extra reinforcing ligaments, so like in your knee, that's like the ACL, PCL. You've got lateral and medial collateral ligaments. Okay? Nerves and blood vessels, just like just about everything. And you may also experience, this is a 7th thing, you may also have things like bursae or a meniscus or a tendon sheath, depending on the needs of that area. Bursae are teeny little circular pockets that act like ball bearings in joints that help facilitate its movements. You find a lot of those in your shoulder, for example, in your glenohumeral joint. You have a meniscus in your knee on top of your tibia, a dense, thick, cartilaginous pad that prevents all that weight from wearing down your tibia, for example. Going back to the synovial fluid for a minute, this is free within the articular cavity. It also gets thinner with activity. So it has some viscosity to it, but when you kind of move it around and warm it up a little bit, it gets thinner and it helps your joints move a little more freely. So when you are warming up, for example, at a workout, you're doing some fairly light, low strenuousness activity, that is going to, among other things, help your synovial fluid thin out a little bit so that your joints, frankly, just work a little bit better with a little less effort. The cartilage itself is already pretty slippery. The synovial fluid helps the cartilage slip past the other band of cartilage even better, though, because it is so slippery. If for some reason that synovial fluid leaks out, it's called you're weeping your lubrication in that joint. If it even like weeps out in between movements within the synovial cavity, you'll still refer to it at the same time. So you have some compression, you have some movement, that lubrication will weep away, so you have this thin film that'll slip, and then when you're not moving anymore, it can sort of slip back in. Synovial joints can allow for gliding, which is where a bone slips over another, which you're used to with like your carpals and tarsals. They sort of move around like balls and you have a full range of motion. You can have different kinds of angular movement as well, which you should be familiar with because of your lab. You can have flexion, extension, abduction, abduction, and adduction, and circumduction, and that's something you're really only going to do with your arm for the most part, or your head, where you move it in or legs in a cone shape in space, which is really a combination of flexion, extension, and some abduction. You can also allow for rotation and then some specialized movements. Supination is, so if you're laying supine, you're laying face up, or if you're the whole anterior aspect of your body facing the ceiling in normal anatomical position. So restoring yourself to normal anatomical position in that orientation is referred to as supination. Put your arm down on the table with your palm facing up. Your arm is supine. Turn it down so your palm is facing down, or flip yourself over so you're laying on your stomach. Now you have pronated. You pronate that limb. Dorsiflexion and plantar flexion have to do with your foot. Plantar flexion is pointing your foot, dorsiflexion is raising your foot. That seems a little bit backwards until you remember that these terms were coined for animals, quadrupeds, and not us. And if you think about what you would look like if you were on all fours and not on your knees but on your feet, that makes some sense. Inversion and eversion, that also has to do with your foot. Inversion is where you bow your feet out so that the bottom of your foot faces in, and eversion is the other way around, so the bottom of your foot faces out. Protraction, retraction, you can protrude, push forward your mandible or pull it back. Elevation, depression, same thing. You can close your mouth, you can elevate your mandible, or you can open your mouth, depress your mandible. And opposition is with your digits, where you can touch your thumb to your forefinger. Those oppose one another, and they have their own special, their muscles that help do that have their own special names. As opposed to being a flexor or an extensor, they have opponents in the name. Breathe through the knee. It's the largest joint. It's by far the most complex joint. You have bursae, you have menisci, you have connecting ligaments, you have your a patella, this sesamoid bone that's going to help facilitate the whole thing. You've got big beefy muscles in the area, ACL, PCL, lateral collateral, medial collateral, tons of stuff going on here. The menisci that I was talking about rest on the tibial condyles, and the femoral condyles rest on those menisci and can help glide over it. And this is in addition to the articular cartilage on the femur. There is some limited amount of rotation that can be accommodated, but it's not much. You can play with that sitting down at your chair. Hold your femur in place, and you might need to actually hold it down, and then try to turn your lower leg side to side, like rotate it side to side and see how much room you have. It's not nearly as much as with your lower arm, right? Your shoulder, again, you sacrifice stability for flexibility. It's not weight bearing, so that's fine. This is also something that helped us swing through trees when we used to be tree dwelling creatures, and helps us be able to manipulate our environment in really, really dynamic, diverse ways. It's got an articular capsule like the knee, but it's super thin, super loosey-goosey. Your ligaments are thin and loosey-goosey. Your tendons are too. And really all any of them are doing are just kind of keeping things together as much as they have to, but no more than that. So that's it. Your shoulders tend to dislocate relatively very, very easily, and you end up with more issues because you can move them in different ways, and because you have less to mitigate any of the stressors on that joint friction-wise. Your elbow is kind of a surprisingly complicated hinge joint. Your humerus, this says both your radius and your ulna, and that's kind of true. Your ulna directly encircles the trochlea, and that is a full-blown hinge joint. Your radius sits up kind of against the capitulum of your humerus, but it doesn't really like touch it. It's held on by an articular capsule that surrounds all three of those bones, radius, ulna, and humerus. And so it doesn't articulate the same way as the ulna does. If you ask an orthopedist, they'll talk about the ulna forms a joint with humerus, but the radius forms a joint with your carpals. Because if you look down at a picture of those bones, the radius has this broad distal end that interacts with basically all your carpals. Your ulna basically, or hardly at all, interacts with them. And then there's a space. It has its own like big fat articular capsule. The proximal aspect of your radius is like kind of up against your humerus, sort of, but it doesn't hug it like the ulna does. So at that joint, you have no side-to-side movement, but because you can pronate and supinate your forearm independently, do that palm down, palm up, palm down, palm up without moving your upper arm, those two have a joint with one another. That also even further enhances our range of motion past the glenohumeral joint, past how much the scapula is not even really attached to your body. It's attached by muscles, not any kind of bony joint. Your coxal joint at the acetabulum, again, you sacrifice flexibility for strength. You've got ligaments, you've got big beefy articular capsule, you've got a labrum, which is this cartilage ring around the acetabulum that holds the head of the femur in even better. Big fat muscles that really work to hold that leg in, and it's very, very, very strong, but it has less range of motion than your shoulders. Finally, your TMJ, your temporomandibular joint, is a hinge joint, but it's modified. So it doesn't quite touch the way some other ones do. Really, it's held together at your mandibular condyle and with just a bunch of a fairly loose articular capsule. This is the weakest joint in your body. The lateral ligament will marry with the zygomatic process of your temporal bone and with the ramus of the mandible, so it's fairly long, and the other ones just sort of encircle the joint. If you yawn and you feel a pop, that is your jaw joint, your TMJ, dislocating. Those of us who used to grind our teeth like crazy, we've wound down this joint tremendously. It's not supposed to take any amount of stress, really. It's a super loose joint. So we'll experience that even more easily than some other people will.